I would like to welcome our members from EPN and ATMF to give us a brief introduction so that we can begin the webinar. Over to you, Dr. Richard.
Thank you, dear Dr. Mugambi. Good afternoon, good morning from where you are. We are very glad as EPN to host this webinar with our partners from Access to Medicine Foundation and Medicine Patent Pool. I would like to welcome all of you to this webinar. It's truly an honor for us to be here today. As said, partnering with Access to Medicine Foundation so that we can really learn from the index 2024. As you know, access to essential medicine is a very critical issue, particularly in sub-Saharan Africa. We are facing many challenges related to access to medicines, and I can't really list all of them. We know most of these challenges from the high cost of product, inadequate infrastructures, limited regulatory frameworks. We are also facing the challenge of related to the voluntary licensing, which we strongly as EPN support. Since COVID, we saw the challenges of access to vaccines, the vaccine nationalism, and also all the gaps we faced as Africa especially, and EPN is working to ensure that we can advocate for local manufacturing. And I think this webinar and the index report, we highlight the way which is still the gap we still have in this, especially on the voluntary licensing. We are facing challenges of capacities at the facility levels where we want the product to reach at the affordable price, but because of many challenges related to the supply chain inefficiencies, planning, forecasting, budgeting, procurement, all these challenges are affecting the availability of affordable product. But EPN is also very committed to quality. We run a mini lab network in the continent in partnership with DFAM. And as you know, substandard and falsified product are really a very big threat in access to medicines, but also in patient safety. But also other challenges like limited competition for especially for some of these products, like the product for insulin, for diabetes, especially the insulin and many other products. You have very limited suppliers, and it's good for us to learn which access program they are implementing to ensure that where people are not able to access high quality, the cost of this product can access through different other opportunities. And we thank Access to Medicines because we will learn in this webinar how the work of Access to Medicine Foundation is also, I want to use the word pushing pharmaceutical companies to ensure that they adopt more access program so that the product can reach those most in need in low and middle income countries. So I would like to really invite all our participants who have joined the webinar. We not only seek to raise the awareness about the findings of this index, but also we want to hear from you. We would like to see this webinar to be very interactive. Your experience and insights are crucial as we discuss best practices, successful collaborations, and the ongoing challenges in this field. So our objective today are clear: to enhance awareness of the work being done by the Access to Medicine Foundation and the Medicine Patent Pool, but also gather your feedback and experiences so that we can share effective strategies, establish a framework for ongoing communication, and see how we can foster collaboration to ensure that we collectively work toward access. So I would like to thank you for being part of this important conversation. We look forward to your contribution and to working together towards enhancing equitable access to essential medicines. Thank you for being here. This collaborative webinar is a step in a long journey ahead of us of joint work, and we would like to welcome all our participants to join us in this journey. Thank you, and over to you, Dr. Mugambi.
Thank you, Dr. Richard, for those warm welcome introduction. And we really hope to learn from this webinar, and of course, welcome the participants to also provide a good feedback, a good welcome introduction. From now on, I will welcome our team from the Access to Medicine Foundation. We have Dr. Shadavi Chauhan and also Dr. Marjin Vehov, who will be taking us through this webinar. So Dr. Shadavi Chauhan is the Government Engagement and Policy Manager at Access to Medicine Foundation. She is responsible for the dissemination of the foundation research findings to a diverse range of stakeholders and identifying opportunities for collaboration and change making. Shadavi also manages the foundation's development strategy and its fundraising activities. She has over 10 years of experience as a nonprofit professional, and also she has gained extensive experience in program management, government and stakeholder relations, public policy, as well as funding in various global settings, including both high-income countries and low and middle-income countries such as India, USA, Trinidad, and Tobago. Prior to joining the foundation, Dr. Shadavi gained valuable experience working in global health and access space as a project manager for PEPFAR, but also with the national government for Trinidad and Tobago. She holds a Bachelor of Arts in Political Science from the Lady Shri Ram College, and also a Master's of Science in International Relations from the London School of Economics. But then again, we are also joined by Marjin Vehov, who is the Director of Operations from the Access to Medicine Foundation. He oversees implementation of strategy, tracking of foundation progress, but also conducting internal alignment. Furthermore, he is the Interim Director of Government and Engagement Policy. In that role, he liaises with government and private foundation, as well as multilateral organizations that are actively working to improve global health and access to medicine. He also oversees the foundation fundraising activities. Prior to assuming this role, he was the Director of Research, where he led research team, steered key initiatives, but also drove high-quality research outcomes that contributed to impactful change. Marjin is a pharmacist by training. He holds a master's degree in pharmaceutical sciences from the Utrecht University in Netherlands, where he completed a thesis on medication-related hospital admission. Before joining the foundation, Marjin spent 5 years working in marketing and medical affairs in multinational pharmaceutical companies in roles related to immunology and infectious diseases. Marjin worked at the foundation as a researcher before heading the company engagement for 4 years, and of course, before taking the role of becoming the Director of Research. So welcome, Shadavi and Marjin, and please feel free to take us through the Access to Medicine Index report. Thank you. Over to you.
Hi, good morning, good afternoon, all. I hope you can see the presentation on your screens as well.
Yes, we can see the presentation.
Thank you so much for confirming that, Mugambi. Once again, I think we've already had a brilliant introduction, thanks to Dr. Richard and Dr. Mugambi, but very quickly, thank you from the Access to Medicine Foundation for this opportunity to allow us to share not just about our work, but also, as Dr. Richard rightly said, about our most recent iteration of the Access to Medicine Index, which was published in November of last year. I don't think I need to do any rounds of introduction. We've already had a very nice introduction done by Dr. Mugambi. So I will get us started right away and talk to you about the Access to Medicine Index. Brilliant. So before we talk about the index, please allow me to very quickly talk to you about the foundation and explain what we are doing at the foundation. So at the Access to Medicine Foundation, our mandate is to mobilize and stimulate essential healthcare companies to facilitate better access to their products, specifically for people living in low and middle income countries. We have been working with this mandate for over 20 years now, and we are very determined to ensure that we can keep the objectivity of our findings. The way we manage to ensure the objectivity of our findings is, as you can see captured on the screen, we serve as an independent nonprofit research organization. What that means is we do not accept any funding for our work from the pharmaceutical industry or any of the companies that we are analyzing through our reports. We have been successful in carrying out our work in this independent and objective manner because of the generous support of our funders, whom you can see captured at the bottom of the slide deck. Very quickly, sharing the names. This includes UK's FCDO, which is the Foreign Commonwealth and Development Office, the Dutch Ministries of Foreign Affairs, Gates Foundation, Hemsley Charitable Trust, Wellcome Trust, AXA Investment Managers, and Stewart Investors. So like I said, we have been in existence for approximately 20 years. We are known for being an independent nonprofit organization. Our primary output does come in the form of research publications, but we are very keen to ensure that our work doesn't stop with just the publication of a research project. We want to ensure that we are actively utilizing these research reports to drive change making. And the way we have ensured to do so is what I'm trying to show through this slide. We call this our theory of change. So to talk you through what this entails, even prior to the publication of a research report, the Access to Index being an example of that, we have a broad multi-stakeholder consultation on what the expectations from this report are going to be, what the ultimate objective of this report is going to be, and also what would be the most effective tools coming out of this report. The intent is to ensure that we are getting feedback from a multiple group of stakeholders, not just prior to the development of the report, but also post its publication, so we continue to engage all the critical stakeholders actively on an ongoing basis. What's also important to show is that our reports not just highlight the roles that pharmaceutical companies can play when it comes to facilitating better access to essential products, but also the role that should be played by other critical stakeholders, which of course includes governments that we talk to and engage with, but also institutional investors who are investing in these pharmaceutical companies. And most importantly, for today's crowd, it's important to share that we are looking for opportunities to talk to partner organizations like yourself to not just share what we have found through our research findings, but also explore what more can be done. What we do through our research publications is not only are we identifying opportunities for the companies to work towards, but we consciously keep a close track of how companies are performing against these opportunities. So we continue to track their progress and we continue to report back on these. What this allows us to do is have a longitudinal assessment of how companies have evolved from the first time we started to do this assessment. What's also important to share is that we are aware of the fact that it's not just opportunities for companies that need to get highlighted, but also some best practices that companies have been imbibing over the years. These are important from our perspective to share, not just with other pharmaceutical companies, but global health stakeholders, because we realized a lot of the pharmaceutical companies were working in silos and there was not much exchange of information about best practices occurring. We have seen through successful examples, when we have shared best practices, there has been an uptake of such practices by more pharmaceutical companies, and we do want to continue moving the needle through this particular strategy of ours. And lastly, we continue to engage with all stakeholders in a strategic manner. And what we mean by that is not only do we ensure that our reports and engagements are aligned with global healthcare priorities, but we also ensure that all the engagement activities that we carry out with the different stakeholders align with your projects, and they can essentially make sense for your upcoming priorities so you can use our reports in an effective manner. With that, I want to now talk about the Access to Medicine Index, what we are here to talk more about today. And before I talk about the 2024 index itself, I wanted to share this particular slide because it helps you get a timeline of how long the index as a tool has been around. So you can see from this slide that the first iteration of the Access to Medicine Index was published in 2008. So it's been almost 15 years since our first publication. The index is a biennial publication. What that means is we do have a 2-year cycle for the subsequent iteration to be published. What happens in that time frame is not only do we develop a new methodology, which would guide the subsequent iteration of the index, but we also do a lot of the stakeholder consultations that I referred to in my previous slide. We have successively over the years, not just strengthen the outputs of the index, but ensure that we are making this a more effective tool of change for all the stakeholders who are more increasingly using the index on an ongoing basis. And we have impact examples to show that not have only pharmaceutical companies engaged with us in an increasing way, but so have institutional investors, governments, and partners. So as you can see on the slide, the most recent publication of the index was the 2024 index, and that is what I will talk to you about today. Through this slide, I quickly wanted to share what the scope of the 2024 index is. So as you can see, and as Dr. Richard already shared, within the index, we are looking at 20 of the largest research-based pharmaceutical companies. We do so because we realize that these companies are, they have the capacity, they have the technical know-how, they have the resources that are required to contribute to the health equity agenda that both the Access to Medicine Index and, the Access to Medicine Foundation and EPN collectively are trying to work towards. The 20 companies that we are analyzing will be shared in the subsequent slide. I have all the names listed out for you, but quickly I wanted to share that we select these companies not just based on their market cap and their revenue, but we also look at the relevance of the product portfolio, the pipelines for diseases, and the countries that they're operating out of to ensure that they're aligning with the scope of our work here at the foundation. In terms of the geographic scope, our last iteration of the index looked at a total of 113 low and middle income countries. It's worthwhile to share with you that we determined the geographic scope not just based on WHO's income classification, but we're also looking at UNDP's Income Inequality Index to ensure that we have a broad scope of countries being covered. In terms of the diseases that the index is looking at, maybe it's worthwhile to share with you that 100% of these diseases impact EPN territories. And just to break it down for you, we are looking at a total of 81 diseases, conditions, and pathogens, which of course includes communicable diseases, non-communicable diseases, neglected tropical diseases, maternal and newborn health conditions, and priority pathogens as well. And finally, to just give you a breakdown of the products that the index is looking at, I will not walk you through each one of them, but you can see from this slide, we have intentionally kept the scope of the products broad because we did want to try and assess the different strategies that the companies are applying to make access a reality across their different initiatives and efforts. So as I shared, as I shared, through this slide, I wanted to give you a quick sense of what are the 20 companies that the index is looking at. And you can see the market cap, the revenue for each of these companies captured in this slide as well. But like I said, in addition to the market cap and revenue, what factors into the selection of these companies is actually the portfolio and the geographic reach, which are critical components for us to consider when we're looking at company efforts to facilitate access to LMIC countries. So with the scope having been shared with you, I wanted to also walk you through the methodology which went into the development of the index. And this is important because we spend a lot of time trying to make sure that every iteration of the index is, an effective tool of change. So for the 2024 index, the methodology was published in 2023. And you can see that we are analyzing the 20 companies' efforts across 3 broad technical areas. These are governance of access, research and development, and product delivery. While you can see that there's a total of 32 indicators that we are analyzing company efforts, in terms of facilitating access, you can see that the governance of access technical area covers 7 indicators, and the same is for research and development. The product delivery technical area has the highest number of indicators, and it also is the technical area which has the highest weightage in terms of company efforts for making access a reality. What I did do on this slide was I boxed a new priority topic, which we have included in this iteration of the index, which is also a good window into the direction that we as a foundation are traveling. So for the last iteration of the index, within our governance of access technical area, we included a stand-alone priority topic on the efforts that companies are taking to measure and report on the patient reach of their initiatives. When I did the first briefing for this particular index with Dr. Richard was very happy to see this included, because he did share with me in one of his consultations with our CEO, Dr. Iyer, he had recommended that we should be making more of a concerted efforts towards capturing the patient reach of company initiatives. So this just goes to give you an example of how we really appreciate feedback, and that's exactly the kind of feedback we're hoping to get from you after our presentation today itself. Very quickly talking through the other technical areas. In our research and development technical area, we have broadened the scope in this iteration to include all projects being developed from phase 2 of clinical trials. Previously, we were looking at just priority R&D projects, so there hasn't been an expansion of scope. And in terms of product delivery technical area, we have supplemented the increased emphasis on patient reach efforts, and this is reflected in each of the indicators which are covered under this particular technical area of assessment. Very quickly, I wanted to share this slide because we do acknowledge that the Access to Medicine Index is a long research document. It is over 200 pages. But through this, we wanted to bring your attention to what we call the primary features of the index, which is a quick reference in case you yourself are trying to use the index for your upcoming conversations, or you need it as a quick reference document. So the first part of the index that I want to highlight for you is the fact that within the index, we have 20 detailed company-specific report cards. We also call these our primary drivers of change, because each report card not just captures the exact ranking of this company in this particular iteration of the index, but it also provides you 3 to 4 company-specific opportunities, which we have identified by our assessment in this period of analysis. And these opportunities are developed, again, based on broad consultations, and we ensure to also work very closely with companies in this particular period to ensure that we can get them to do more in that regard. So if you have any upcoming meetings with any specific company that we are analyzing, feel free to go to the company report cards, look at these opportunities, and if required, get back to us to see if we can support you, to take the conversation forward with any specific opportunity from the report card itself. What the index also has is we have 3 key findings, which are broad industry trends that we have seen across the 20 companies. I will share these in more detail with you right now. As I shared, we are assessing companies on 3 technical areas, which I spoke to you about in the previous slide. What's important, as I said, we always ensure that we are trying to identify best practices, which are worthy of being shared with not just other pharmaceutical companies, but global health stakeholders. So we have 8 best practices identified in this iteration. And I guess the scope is being repeated again, but we are looking at 81 diseases, conditions, and pathogens across 113 low and middle income countries. Sorry. Yeah. So to get started, I Okay, yeah, just want to make sure. Brilliant. We just wanted to make sure that we were following the chat in case of any questions. So to get started on the key findings, as I said, we do have 3 key findings in this particular iteration of the index. And the first one is our key finding around inclusive business models. This is a promising finding. I would like to start off by saying that, because we did see that traditional access strategies of companies tend to favor upper middle income countries as opposed to lower middle income countries, and even more so when we compare it to the strategies for low income countries. A prominent finding in this regard was that when we analyzed the access strategies which were in place for the products that we were looking at within the index, we realized that only 39% of these products had access strategies for low-income countries, and this number stood at 76% for low and middle-income countries, and it was 85% for upper middle-income countries. So what this goes to show is that companies still are shaping their access strategies to cater for upper middle-income countries, and there's still quite a way to go for them to start expanding this to low-income countries. With this finding, when we did an assessment of what are some of the mechanisms that these companies are using to make their products available to low-income countries or least developed countries, we found that a few companies are using their inclusive business models as an effective mechanism to bridge the gap in this regard. I will talk to you more about what these inclusive business models are through my next slide. Thanks, Tom. I have to do this from here. Sorry about that. So as I said, we found the inclusive business models to be an effective mechanism being utilized by companies. And out of the total, in all, we saw that there were 11 inclusive business models across the 20 companies that we are analyzing. However, we wanted to highlight just 5 out of those 11 models. And the reason for that was we want to ensure that the business models that we are highlighting as the key findings are comprehensive. And what we mean by comprehensive is we wanted to ensure that these models had potential for scalability, which is to say that they can expand expand their programs to include more products or more countries as required. And furthermore, we also wanted to see if these inclusive business models were working with local partners like yourselves to address local barriers to make access a reality on the ground in a sustainable manner. And what we realized was that these 5 companies, through their inclusive business models, were doing both of these. Just to quickly name the 5 business models, I looked at Novartis' Sub-Saharan Africa Business Unit, Novo Nordisk's iCare, Sanofi's Global Health Unit, Pfizer's Accord for a Healthier World, and BMS's Aspire model. The years that you see noted again, each of these models marks the year that these models were launched. If you look at this map, you will see that cumulatively, these 5 business models have an impressive geographic reach. They are committed to operate in a total of 102 countries, including all African countries in the scope of assessment. So if these models were to be successfully implemented, we do believe that can be a very effective mechanism for facilitating access to these countries within the scope of our assessment. What's also good to highlight is in Sub-Saharan Africa, an average of 4 models per country was noted out of the 5 models that we are talking about. However, as we said in the key finding itself, while this is a promising trend, we do feel there are significant gaps remaining. And the gaps that we see in regard to these inclusive business models come with the monitoring, reporting of the patient reach of these models as they stand right now. I'd like to share that out of these 5 business models, Sanofi was the only company which is actively doing a reporting back on the number of patients that its global health unit is reaching out to. Outside of that, we are lacking similar reporting of patients reached or population served by the other business models. And we have created opportunities around this for these companies in their own respective report cards. I have to maneuver this from here. Very quickly, we have spoken about the business models, but it's worthwhile to look at the product portfolio of these models. And as you can see from this slide, it's quite a varied product portfolio across the 5 models. But what's worth highlighting is that almost 73% of the products covered by these business models are looking at NCD products. This might not be surprising for most of you on the call because, as you know, R&D for NCDs is becoming the backbone for pharmaceutical companies. And it's also a promising trend given the fact that LMICs do bear the heaviest burden of NCD disease burden. So it's actually a promising trend in that regard that these inclusive business models are facilitating better access to NCD products. However, we also know that while the global burden of communicable diseases has gone down, it continues to be a pressing burden for low and middle income countries. And the fact that only 27% of the product portfolio is looking at communicable diseases is a finding that we wanted to highlight because we believe, as EPN being a successful partner for a lot of the companies which are captured on this slide, in your conversations, you could maybe facilitate a movement for these portfolios to have more communicable disease products included in their portfolios. And as you can see, that only less than approximately 1 in every 4 products in these models are currently looking at communicable diseases. And these 2 are limited primarily to malaria and neglected tropical diseases. Through this slide, I wanted to show already some very effective partnerships which are going on with these leading pharmaceutical companies, which includes, of course, some of the EPN members who might have joined the call today. You can see that the companies are not just working with faith-based organizations, they're also working with partners like international organizations, the academia, distributors, patients, medicals, and scientific associations, as well as the private sector. So we wanted to just share this slide to show which of the EPN members are actively already working with these pharmaceutical companies. We want to thank you for your partnership. And we hope that we can encourage, by sharing these examples, more EPN members to uptake the partnership with some of these pharmaceutical companies to expand access in their own jurisdictions. We also, through this slide, wanted to share the other partners that are working in the space. So you could maybe elaborate your own coalition with these partners to streamline efforts when you are trying to work with pharma companies to get them to address the most pressing needs on the ground. That was key finding 1, and I would now talk you through key finding 3. The reason I'm skipping key finding 2 is because we felt that key finding 1 and 3 are more aligned with EPN's direct area of work and priority. As Dr. Richard also shared, we acknowledge that voluntary licensing and technology transfer is something that EPN is actively working on. So we did want to address this before we go to our key finding 2. So when we did an assessment of the company's voluntary licensing and technology transfer initiatives, we realized that the efforts to ramp up access and availability through these 2 mechanisms has been somewhat limited. To explain what we mean by that, we have this bar graph, which is very self-explanatory. So you can see when we did a comparison of the number of non-exclusive voluntary licenses, which were issued in 2022, as compared to the ones which were issued for the period of analysis for the 2024 index, there has been a significant drop. So in the 2022 index, we had analyzed a total of 6 of such licenses, and in 2024, there were just 2. There are a variety of reasons for this drastic drop, if I could say so. But of course, one prominent reason, which all of you might already be aware of, was the fact that the 2022 index did coincide with the COVID-19 pandemic years, and there was an uptake of licenses at the time for that reason. But also what's worthwhile to flag here, which aligns well with our findings for the inclusive business models, is that more and more companies are moving their R&D efforts towards NCD products. And when we look at companies' traditional voluntary licensing patterns, we see that companies were licensing more for communicable diseases products. But given that the R&D for such products has gone down, that could also be a reason that we are seeing a slowing down of such licensing activities. Having said that, I do want to talk to you about the 2 licenses that we saw issued in this period of analysis. The first was for CAB-LA, which of course is an HIV pre-exposure prophylaxis, which is developed by Viv Healthcare, which is majorly owned by GSK. And the second was for nilotinib, which was licensed by Novartis. was a very critical development from our assessment, because this was the first time that a company licensed for an NCD product. We were hopeful that this will lead to similar actions by other pharmaceutical companies within the scope of our assessment, but as you can see, that was not the case. What's also worthwhile to highlight is that both of these licenses were issued towards the second half of 2022, and ever since then, we did not see any new licenses getting issued till the 31st of May 2024, when we stopped our period of analysis for the 2024 index. We do know that Gilead did announce its licensing for lenacapavir, which is another HIV PrEP option, but that happened in October of 2024, which was outside of our scope of assessment for the 2024 index. So that particular activity would be noted in our subsequent iteration of the index, but for this index, we only saw these two licenses getting issued by the 20 companies that we were analyzing. We know that voluntary licensing, when supplemented with technology transfers, can be a very powerful tool for facilitating access. So we wanted to show you how companies did with regard to technology transfers. In this period of assessment, we saw a total of 47 technology transfers being done by these companies. What's worthwhile to share, which again might not come as a surprise, is that most of these tech transfers are concentrated in upper middle income countries. So out of the 47, we saw 11 tech transfers going to India. There were 9 to Brazil and 7 to China. For Africa, we saw a total of 17 initiatives across these 20 companies. And there too, it was primarily concentrated for South Africa and Algeria, with both of these countries getting 5 out of 5 tech transfers each. So we see that the tech transfer initiatives are still very limited in terms of their reach for the LMIC countries that we are analyzing within the index. What's also worthwhile to share with you is that only 6 companies established tech transfer initiatives for sub-Saharan Africa, and these were primarily for products, mostly looking at communicable diseases, be it HIV, COVID-19, hepatitis C. There were a few for non-communicable diseases, which was a promising trend, and I will share more about it in the next slide as well. But these were for diabetes more specifically, and this again we know is something that EPN has actually been partnering with some of the companies on. So we do want to talk a little bit more about it. You can already see boxed out on this sheet the partners that these companies have been working with, more specifically for sub-Saharan Africa. And we know that Sanofi has been working with BioVac for its polio vaccine. Even though polio is outside of a scope of assessment, we did want to highlight it, and we see it as a very positive trend. And we know that Boehringer Ingelheim has been working with Botswana's Vaccine Institute, and Novo Nordisk has been working with Aspen for its human insulin. And Merck KGaA has been working with Universal Corporation Limited in Kenya for its schistosomiasis treatment as well. As I said, we did see some technology transfers for diabetes, or rather for communicable diseases, but we wanted to specifically pull out the ones that we saw for diabetes because this was a positive trend. So already what's worthwhile to share is that from the 2022 index, we saw the number of technology transfers going up from just 4 in 2022 to now 10 in this round of assessment. While most of these tech transfers have been for human insulin, it's worthwhile to flag that Eli Lilly is actually also doing technology transfers for its analog insulin in Egypt and Bangladesh. Novo Nordisk, as I shared previously, is working with Aspen in South Africa for manufacturing of its human insulin. We also assess a third big insulin manufacturer within the index, which is Sanofi. While Sanofi does not have any active technology transfer initiatives for the region, what's worthwhile to highlight is Sanofi, through its global health unit, is making its impact brand analog insulin available to a lot of the countries within our scope of assessment. Sanofi is also working in health system strengthening initiatives with this regard to just build up capacity in the countries, and more specifically in Tanzania. Of course, with voluntary licensing technology transfers, we also wanted to shine a light on the company's local manufacturing efforts. And this map, in a way, duplicates our findings around the technology transfer patterns of the companies. You can see, once again, companies' manufacturing efforts continue to be concentrated for upper middle income countries. China has 13, followed by Brazil with 8. We have Indonesia and Mexico followed by India. So once again, the local manufacturing presence is very concentrated in upper middle income countries. This is, of course, as Dr. Richard said in his opening remarks, something that we are hoping will change, will evolve as we work with partner organizations like yourself, but also AMA to see how we can facilitate further movement in this regard. More specifically, to say where we're hoping to see EPN's partnership help shape this is we're hoping that EPN can help us to establish conditions which prioritize these leading pharmaceutical companies to partner with local manufacturers in the region. So there is more initiatives being taken by these leading pharmaceutical companies to facilitate local manufacturing in the region. And we also believe that as a major procurer for the region, EPN can support with providing volume guarantees to encourage local manufacturers to accept technology transfers from R&D companies to facilitate this process. And finally, I come to the last key finding, which is our key finding 2 around clinical trials. And what we found through this particular key finding was that patients in low and middle income countries are largely being left outside of clinical trials, which in its turn is limiting access to new treatments. So from this map, once again, you can see that companies are continuing to prioritize high and medium income countries for clinical trials, with less than 50% of all clinical trials being conducted in any of the 113 countries that we're looking at. What's even more dismal is when we do a zoom in and see the number of clinical trials in low-income countries, and that just stands at 3.5%. This is a lost opportunity from our perspective because 15 out of the 20 companies that we are analyzing within the index have public commitments stating that they will make access or they will facilitate access in the countries where they are conducting clinical trials. But the fact that they are not conducting clinical trials in more than 50% of the countries tells you that that access opportunity associated with this commitment gets lost. If we do an assessment of the products that the clinical trials are being conducted for, we see that for low-income countries, they continue to be focused on communicable diseases and neglected tropical diseases. And you can see a split of this in this pie chart, where there is a lot of emphasis on products for HIV/AIDS, for malaria, and then finally for neglected tropical diseases in that order. So that was the 3 key findings. What I wanted to also very quickly share in addition to the key findings was some additional findings which we believe align very well with EPN's priority areas and areas of work. So let me please start with our first finding, which was around an assessment of the different access strategies that the companies are utilizing to make their products available in the low and middle income countries, once again, within our scope. And what we see, broadly speaking, is that companies are adopting more comprehensive access strategies or for upper middle income countries. You can see this by the fact that there is a combination of public and private routes to increase the supply of products. Furthermore, companies are also using financing mechanisms which are supporting consumers' capability to pay out of pocket, which is directly addressing the matter of affordability, which is at the heart of EPN's area of work as well. When we look at the implementation of such strategies for low-income countries, we see it's lacking in its implementation for low-income countries. When we're looking at the strategies being used for low-income countries, we see there's quite a lot of companies using donations as a strategy to make the products available, which of course is a very useful mechanism to facilitate access. However, it's not a sustainable one. And more recently, as we shared through our key finding, a lot of companies are using inclusive business models to make their products more readily available to such countries. We believe companies have an opportunity to combine multiple of these strategies, and that is what makes their strategy more comprehensive and more effective. So we wanted to showcase the different options that are there for the companies and encourage companies to uptake a combination of these to see how best they can facilitate access by expanding their current areas of work. I also wanted to give you an example of what a best practice in this regard might look like. So you can find this in Novartis's report card, but also in the best practices within the index, where we have highlighted that Novartis, through its Sub-Saharan Africa unit, is using a combination of these strategies. For example, it's using tiered pricing, second brand investments, and also trying to work on health system strengthening to address access barriers. So it's an example of a company trying to use multiple mechanisms, and that has actually translated into more effective access, because Novartis, as you will also hear me share in a subsequent slide, has the broadest geographic reach as compared to its peers for the products in its portfolio. So it has been effective for the company. We also have a few good practices where we know Novo Nordisk is working with partners like EPN to limit the markups on human insulin products. And further, we also have an example of Pfizer working with M-Pharma to reduce the markups for countries like Ghana and Nigeria for 5 of its products that we have analyzed within the index. We also wanted to show a map, which is, as you might realize, slightly different to what we were seeing in terms of transfer technology transfers in local manufacturing. If we do an assessment of the countries getting the highest number of products through donor-based pool procurements, we do realize that countries in Sub-Saharan Africa are the highest recipients in that regard. While we do share that this was a finding of the 2024 index, where we stopped our assessment in May of the year of last year, we are cognizant of how the global landscape is evolving as we speak, and we do know that there might be changes which come up. But what we also want to acknowledge is a realization with this changing landscape that there is an opportunity for local players like AMA for the Africa Pool Procurement Mechanism to maybe step in and expand their role in terms of ensuring that pool procurement, in terms of demand guarantees, in terms of assurance of continued availability of products, continues to be a viable option for these countries. Finally, I'm almost to the end of my presentation. I want to quickly talk to you, as I said, about the broad industry trends that we saw, and then I will talk you through the rankings of the companies themselves. So through this slide, we have developed infographics, which are talking about the 3 technical areas where we analyze the companies. The first one in orange talks about our governance of access technical area. The second in green is about research and development. And the purple multidimensional one is around product delivery. So starting off with the governance of access technical area, I have boxed certain indicators, and this was based on my previous interactions with EPN, just to highlight maybe priority topics that align very closely with your area of interest, your area of work. But please feel free to give me feedback after if I had missed something. But in governance of access, we have seen more or less there being strong performance by companies in the governance and strategy indicator, as well as for the responsible business practices indicator. As compared to those two, if you look at the performance of companies in measuring and reporting of patient reach, there is quite a large scope for companies to improve on this. With that, I would like to share this was the first time we were doing this assessment. So we do know there's a lot of potential for us to have these conversations with companies to explain what we are trying to analyze within this indicator and hopefully help them improve the performance against this. We also, like I said, are looking at the research and development efforts of the companies as reflected by the green triangle on your right. Unfortunately, this is one technical area where we saw poor performance across all the indicators that we were looking at, and more specifically around product development. The reason I wanted to highlight there has been low performance in building R&D capacity is also because it ties in well with our key finding around the low uptake of clinical trials. I do remember from a previous conversation that Dr. Richard has shared that this is an area that EPN might want to support in terms of helping increase the uptake of this. So I'm looking forward to hearing your comments around this, and also around access planning, because it's important to highlight this, because as we see companies move away their priority R&D from towards NCD products, we see the number of access plans that they have is dropping. And this is because a lesser number of NCD products are being developed by support of donors who mandate access planning from these pharmaceutical companies. So in the absence of such mandates on pharmaceutical companies to have access planning from donors, we want partners like EPN to step in and through their collaboration and engagement with these companies, ask companies to uptake access planning from early stages of product development, because we don't want access planning to be an afterthought after a product has been launched, because we believe that's an opportunity lost. So that's one that I did want to talk you through. And finally, quickly talking about the product delivery technical area, we see there's a varied performance, but of course there are some areas where EPN is directly engaged with, be it inclusive business models. It has been a key finding, but you can see by the rating here, there is still scope for development, which also means there is scope for more EPN members actively engaging with these pharmaceutical companies to get them to work with them in an effective manner. Furthermore, when we are looking at quality and supply, there has been a high performance by companies in this regard. But once again, keen to hear what EPN's experience has been, because this is also directly within your scope of work. And health system strengthening has been, again, a strong performing indicator across companies. And local manufacturing is one where we do want to see a better uptake by the companies, at least the 20 that we are analyzing. And this finally gets me to the ranking of the 2024 index, which I believe a lot of you might have already seen. You can see there has been a lot of movement in the company positions. To quickly explain it to you, the rankings that you see on the left-hand side are the rankings for this year. And of course, the ones in gray are what where they ranked in the last iteration of the index, which was in 2022. You can see Novartis has taken the top spot for the first time. This is the first time since we published the first iteration of the index in 2018. So it's a big jump for the company. But to give you a little background as to how the company achieved this, there were several factors. But like I shared, Novartis has been able to demonstrate the implementation of its policy into practice, which has demonstrated itself in the number of patients the company is reaching. It does have the broadest geographic reach as compared to any of its peers. And furthermore, Novartis also has the largest number of projects in development to address R&D gaps for malaria. And this also includes certain formulations for pediatric populations. So these are just a few of the reasons that I wanted to share, which have caused Novartis to jump up in its position, be number one. GSK, of course, is a close follower, but it's a leader. We do want to acknowledge this because GSK also performs very strongly across all the three technical areas. But what's worthwhile to share is that GSK has the largest priority pipeline out of all the companies that we are analyzing within the index. Certain other companies that I know EPN is working with, and I want to flag some developments of, is both Sanofi and Pfizer have jumped up in their ratings, and you can see they've entered top 5 as compared to the last iteration of the index. And of course, this has been because of several factors, but it also more specifically includes both the company's efforts to make the products available to low-income countries through the inclusive business models. AstraZeneca is again another company that I know EPN actively works with, but we wanted to share that in combination to supporting the local manufacturing presence or the local manufacturing capabilities of LMICs. AstraZeneca is actively also working more specifically to support local manufacturing efforts for diabetes products, which is again something that EPN works closely with. And the last company that I do want to share a little bit about is Johnson & Johnson, because I know Johnson & Johnson was working with EPN for various projects, but more specifically for developing a curriculum for supply chain management. And this is an indicator which has been considered by us when we were developing the index, and it has contributed to the company's ranking, as you see here. Novo Nordisk is another very important company that we wanted to highlight as the last one from this list, because we do know that they are actively closely working with EPN, and they have been playing a very critical role. However, what's worth highlighting is that they have lesser number of projects as compared to the other companies. And Moran, of course, through his panel session, can talk more about what led to the different companies' rankings. But this is, I guess, a quick summary of the list. And I guess I've captured all the companies that you are actively engaging with. But if you are curious about any specific company and want to know more, please do let us know. We'll be happy to answer that. I think I have just one last slide where I want to talk to you about What we can do as a next step from this presentation from today's meeting is we would really appreciate the support of EPN to identify key parameters that can actively impact access in all the areas of your jurisdiction. So we are hoping to get your feedback in that regard. We also believe that EPN can play a very critical role in defining and enforcing policies which can enable pharmaceutical companies to prioritize access to critical healthcare products and solutions in sub-Saharan Africa. An example is EPN's ongoing collaboration with Novo Nordisk for human insulins. Furthermore, we do believe that EPN can help us identify key disease areas that require innovation so that we can move the needle from our end to talk to these R&D companies for possible tech transfer partnerships with local manufacturers. We do believe there's a lot for us to learn from you, and specifically in terms of the affordability and quality interventions that EPN has tried that we should be more informed of and support with. And finally, we do want to ensure that we can create an ongoing feedback mechanism where we can continue working with the EPN members to see how we could support your ongoing initiatives and actually facilitate better collaboration with these leading pharmaceutical companies. So I would stop with that.
Thank you very much, Sadavi and the team from ATMF for that wonderful presentation. We can see there is a lot of insights from the ATMF index, but I see also a lot of in-depth insights that have been able to be uncovered when it comes to what some of the pharmaceutical companies are doing to enhance accessibility of healthcare products and technologies. So without further ado, I think we'll proceed to the panel discussion. And with us today, we have a team of competent panelists from the medicine patent pool, but also we have consultants from the management science of health, but also we have a representative from the EPN network. So I'd like to welcome our first panelist for the day, who is Mahin Verhoef, the Director of Operations at Access to Medicine Foundation. But also to welcome our second panelist. I think I introduced Mahin at the beginning of the presentation. Our second panelist is Tiwado Brahimo, who is the Policy and Advocacy Manager at Medicine's Patent Pool. So Tiwado Brahimo has 24 years of experience spanning both the profit and non-profit sector. His work in the public health has focused mainly on health product access, economics, and policy. He currently works with the Medicine Patent Pool in Geneva, Switzerland, where he contributes to expanding access to innovative healthcare products through intellectual property licensing and technology transfer. So Tiwadayo began his career in the pharmaceutical industry, progressing from a medical representative to a product manager and later to a business development manager. After a decade in the private sector, he transitioned in 2013 to the Creton Health Access Initiative, abbreviated as CHAI, where he worked on public health programs to improve access to medicines. Over the years, he has also provided technical assistance to governments on ongoing health financing policy to support universal health coverage. He holds a master's in health policy, planning and financing from the London School of Economics and the London School of Hygiene and Tropical Medicine, as well as an MBA from the University of Lagos. Tiwadayo is also a pharmacist and a fellow of the West African Postgraduate College of Pharmacists. So welcome, Mr. Tiwadayo, into today's panel discussion. And of course, to go to our third panelist for the day, we have Dr. Joseph Mukoko, who is the Principal Technical Advisor at the Management Science of Health. So Dr. Mukoko holds a bachelor's degree and a postgraduate diploma in epidemiology and has various certifications in supply chain and pharmaceutical health systems training. He has over 24 years of experience working with and also supporting interventions in public, faith-based and private health sectors in strengthening pharmaceutical supply chain systems and overall health systems in Kenya. He has been leading efforts and supporting diverse technical teams, as well as efforts aimed at designing and implementation of pharmaceutical and laboratory systems, and also supporting interventions at the facility level. So Dr. Mukoko currently supports the USAID MTABS program, as well as the USAID Tamasha TB program, among other consultancies under the MSH work in Kenya. Welcome, Dr. Mukoko Joseph. We also have our third panelist, who is one of our EPN members, Grace Ajayokai, who is a pharmacist at the Catholic Health Service Trust in Ghana. So Grace holds a bachelor's of degree in pharmacy and also a master's in philosophy in health services management from the University of Ghana. She is a member of the Pharmaceutical Society of Ghana, as well as the International Pharmaceutical Federation. Grace has 10 years of experience as a pharmacist in the private and faith-based sector. She has consulted widely as an external clinician to the National Health Insurance Authority in conducting clinical and compliance audit. So currently she works with the Catholic Health Service Trust, where she coordinates publication for the institution, but she also coordinates production activities at the Catholic Medicine Center. She has a passion for research and has 8 papers to her credit published in reputable journals. She has also served in the capacity of a reviewer for many journals, and her research interests include adolescence and reproductive health, patient safety, health policy, and global health. So welcome, Grace Ajay, to the panel. So I would like us to begin with the first question, especially to the Access to Medicine Foundation, Mahin. So as part of the Access to Medicine Index that has been shared, I think one of the main things that we have noticed is that during the pandemic, we had several of those companies basically demonstrating the ability to make medicines widely available, which of course shifted the mindset of industries not being able to bring products to the low and middle income countries. However, based on what has been shared, I think from a perspective of licensing and also patent approvals, we are seeing there's a loss of momentum. Could you please kindly help us understand what could be leading in the loss of momentum when it comes to some of these big pharmaceutical companies reducing in terms of their access programs within the low and middle income countries?
Thank you, Dr. Mugambi. Yes, I'm happy to share the thoughts and the findings that we have here. So first of all, if we go back to 2020, 2021, we indeed saw remarkable work coming out of this industry. I mean, every one of you who has been working in vaccines for long enough knows how special it is for companies like Sanofi and GSK, longtime rivals in vaccine development, manufacturing deployment, to work together on a vaccine for COVID-19. At the same time, we saw quite a number of non-exclusive voluntary licenses. I'm sure my colleague from the Medicines Patent Pool will be able to tell more about it. Products that were not even launched had already been offered for a license. So the speed as well as the depth of this approach was quite unique, actually. And of course, one of the reasons, and we're now experiencing some unrest in the stock markets as well, is of course the fact that there was a lot of financial pressure. At the same time, there was a lot of financial opportunity for companies to do the right thing. The pressure, of course, not just came from investors interested in the pharmaceutical industry, but also if you were invested in the automotive industry, you saw shares dropping. So there was every bit of financial incentive to get out of the pandemic. And of course, pharmaceuticals and vaccines were a very critical tool to be developed and to be deployed. So there was this very important financial incentive for not just companies, but also investors to do well and to do it fast. Simultaneously, the financial resources that were available, not just to supply people in high-income countries, but also to support low-income countries and lower middle-income countries, were unusually high compared to normal, especially compared to today. But again, let's take normal as 1 year ago, because people in high-income countries realized that if we want this pandemic to end, we can't just, in isolation make health products accessible and available in high-income countries. I would say that as soon as you saw that the pandemic was fading, not even declared over, but fading, the financial means and the resources were reallocated to perhaps more profitable areas. And again, the focus was back on profit making within companies. At the same time, during the COVID pandemic, so Sabi already referred to the license by Novartis for Tasigna, nilotinib. We were under the impression that this was such a breakthrough to have a license for a product for non-communicable disease that we were anticipating more companies to follow suit. And the COVID pandemic, or the end of the COVID pandemic, does not really justify not seeing more of that activity happening. So we've been quite strict in how we judge and assess the loss of momentum in a sense. At the same time, Sadvi highlighted some of the promises that we see in companies who now, after the COVID pandemic, do seem to truly and sincerely understand some of the problems in low-income countries, some of the shortcomings in how they supply low-income countries or lower middle-income countries. And therefore, we also carefully consider some of that as progress. But again, it's more of a promise today. So we're interested to see where, for example, some of these larger inclusive business models will actually take the products. Will they actually reach vulnerable communities? Will they actually elevate access in the poorest countries? I'll pause here.
Thank you very much, Majin, for that response. And I think clearly looking at the pandemic and how we focused mostly on accessibility of healthcare products, and of course, giving the reason of shifting to more profit-making ventures, it makes a little bit of sense. And I think it brings me more to what Tiwadayo and team is doing. And I think the next question goes to Tiwadayo from the Medicines Patent Pool. Based on the work that you do, especially within the Medicines Patent Pool organization, we understand the work that you do in terms of conducting voluntary licensing, but also working to ensure that we have patent approvals for other pharmaceuticals to be able to produce generic drugs that are within that are affordable within the local, within the low and middle income countries. So based on what Majin has informed us, and also based on what the report has informed us in terms of the stagnation of voluntary licensing, how can pharmaceutical companies be incentivized basically to expand these initiatives so that they can improve the local availability of LMICs, and of course, gauging the work that the Medicines Patent Pool is doing?
Yeah, thank you very much, Mugambi. Once again, good afternoon, everyone. First and foremost, the Access to Medicines Foundation deserves commendation for its important work. It's been a very supportive initiative, and it is extremely valuable in bringing to the consciousness of stakeholders the need to ensure that innovative medicines are available to all, irrespective of where they live. So the report, in my view, highlights the current state of access to medicines, and it underscores the globally, it underscores the importance, or rather the issue that we have where equitable access have not been taken as the norm. It's not yet accepted as a standard policy within the pharmaceutical industry. And that is why it seems as if the trend is slowing. But there are a number of levers that we can use to incentivize companies and to drive improvements. There is no silver bullet, but the global health community can do certain things together, and in some cases, it could just be a few stakeholders that needs to do certain things that can make a difference. I will start from policy, in terms of global policy. Companies respond to signals, predictable signals, in terms of how the body language and precisely the policy of governments or the international community. When governments, multilateral agencies, and donors explicitly prioritize access-oriented licensing and tech transfer, as an example, the companies are likely to align. For instance, from the point of discovery of a product, even from the point of conceptualization of a product, where there are still discussions around the design, how the funding is going to be. If governments that are usually the funders of discovery or basic science or or R&D, if they put certain conditions in the agreement with the companies in terms of access, at that point where the idea is even being put together, that would definitely help access down the line. So it's a form of incentive to say that we're not going to give you this money unless you commit to access to the end product in LMICs. So that way, the company gets incentivized, to ensure that they factor that into their consideration. We shouldn't wait, until the product is almost getting to regulatory approval before we start talking about access. At that point, it becomes more difficult because the companies will already be counting. Sorry, it seems there are some interruptions, or is it from my end only?
Sorry about that. I think I'm muted, sorry.
All right, thanks. So that is one. And I mean, before I move away from that, happily, there are some initiatives that are currently ongoing. From the MPP's perspective, we have always been promoting the inclusion of equitable access into agreements that relates to R&D. Like, for example, we worked with a group called Student for Equitable Access to put together a language that could be incorporated into access in UCLA, University of California, in the United States. So to ensure that research and developments that relates to access, when the funding is being conceptualized, access conditions are included in the agreements. Also in WHO, there is a current negotiation that is going on that people normally refer to as the INB, where countries that are members of the WHO are discussing on how to ensure that when future pandemics break out, there's equitable access to products. So part of the condition, part of the provisions in the agreement that is currently under negotiation is that countries should include conditions for their funding of R&D to include access in LMICs. So we hope that will see the light of the day. Where the agreement is to be concluded this week, but yeah, fingers crossed, we see how it goes. The second thing I want to quickly go into, because I know I don't have all the time, is about financial incentives. Financial incentives to companies could come in different ways. I will just mention maybe 2 or 3. One of the ways that financial incentives could be given that will not constitute a burden to governments is regulatory fast tracking. And I think this will be applicable in many countries, including some LMICs. When regulatory approval is fast-tracked, like for example, in the United States, there is a scheme called PRV, Priority Review Vouchers. So when a company is given that voucher, is given that priority review, their products are given expedited. The process of approval is expedited so that their products can get to market early. So that kind of voucher is usually transferable. For example, a company might decide to say, well, I want to use my voucher for a product that is still in development, that is going to come out that is going to get to approval in the next 1 year, or that is going to come out from R&D in the next 1 year. So if that company already has, an idea of how the market of that product is going to be, so it could be transferred to that product, in which case the product can get to market early. And if a product gets to market early, also means that it has financial implication. Another way is, that priority review could give financial returns to company is where where the company decides to trade the voucher. I mean, in some instances, it runs into millions of dollars, where a product is fast-tracked from like 10 months to like 6 months. So the fact that it's getting to market 3 months or 4 months earlier could translate into huge financial returns for companies. So that's one way. Other ways where companies could be incentivized to share their IP and to do technology transfer could be in terms of tax benefits. Companies could be given tax holidays to say, for example, a company somewhere in high-income country could be promised some form of tax holiday for like a period of time if they can commit to making their product accessible in certain geographies. There are so many others like market commitment, advanced market commitments, subsidies, grants, and social bonds. I will move away from that and pause at reputational incentives. I call it reputational incentives broadly, but there are so many elements of it. Some of it comes from pressure from communities, civil society, and the like, or advocacy. Even the work that the Access to Medicines Index is doing is, also link up to this, where where companies get the nudge to do the right thing. Nobody wants to be seen as not doing well. So when people see their scores, when companies see their scores, it could have the effect of getting them to take steps in order to improve the next time. Then there is also ESG factors. By ESG, I mean environmental, social, and governance objectives. Many companies commit to certain objectives that are seen as critical by investors. So investors want to see companies that are responsible. So if a company licenses its product, it improves their ESG performance. And so therefore, investors are more likely to put their money into those companies. Research have also shown that employees stay longer with companies who have, companies that include ESG commitments, like doing good, ensuring equitable access. So all these factors, put together, there are different tools that could be, that could be used in order to get companies to, to share their technologies. And finally, before I pause, is in relation to de-risking of the licensing process, or supporting companies to actually license. We at MPP, part of the things that we provide, that we provide to companies is getting their products to market without them spending the money, without them bothering themselves about how to manage licensure. So all they just need to do is to license. They don't need to bother, which companies have the capacity to produce in LMICs, where are they located, will they meet the access goals, etc. We do that for them. So that way, we also try to take, that concern, because some of them will complain that they do not have the capacity. We, MPP has the capacity in order to ensure that where any company is intending to license, we can do the licensing. We also have in-house technology transfer team that can support them to ensure that the product get to the end users. I think I'll pause here. Thank you.
Yeah, thank you. Thank you very much, Mr. Tiwadayo, for those insights. And I believe maybe the team will also, the participants will also want to understand how many companies that you've worked with. Also, they might want to understand how many products that you've been able to bring in the low middle income countries. But I think I will shelve it for now as we go to our next panelist. And I think this question goes more to Grace. Grace, based on the ATMF index report, I think we have been able to see that we have 20 companies that really are moving or are really trying to improve the accessibility of healthcare products and technologies in the low and middle income countries. As your work in the Catholic Health Trust, and of course working with the medical stores in Ghana, could you please also share with us some practical examples? What are some of the benefits? Maybe have you received any benefits from some of these access programs? Which are some of these companies maybe we have worked with in terms of these access programs? But also, have they contributed in reducing the cost of medicines in your experience working within the faith-based network?
Okay, thank you, Mugambi, for the question. So for the Catholic Health Service Trust, we benefited from a program with Novo Nordisk. So the organization has signed a memorandum of understanding with Novo Nordisk to facilitate access to diabetes care within our institutions. So over the period, Novo Nordisk has built a capacity of our health professionals as far as diabetes care is concerned. They've also established diabetes support centers in some of our institutions. And even in our main head office in Accra, they helped us establish a clinic which is specialized for diabetes care. And every year when there is a World Diabetes Day, they continue to support the clinic to screen and also create awareness on diabetes. So that is one aspect. But when it comes to the medicines, Novo Nordisk has a local supplier and a local distributor here in Ghana, which is Gokal's Laboratories. So for our institutions, for the organization, we do not warehouse. So once we bid and then we award a contract, the institutions place the order directly, and then the local distributor supplies to the institutions. With Novo Nordisk, their products, the insulins are non-competitive. So no company even bids for that product. It's solely for Novo Nordisk. And then we are able to get it at a very cheap price. So for last year, the price that was given to us was about 24% cheaper than what is on the open markets. So that is how cheap our institutions are able to get the insulin. And once they place the order, the local distributor supplies it directly to the institutions, and taking into consideration the cold chain, everything is intact. They get it and then it's still of good quality. So that is the arrangement we've had with Novo Nordisk for some time. And it's really helping our institutions because mostly we are able to give their products to the client on insurance. But then when the exchange rates continues to become volatile, it becomes a challenge because the price goes up and then it goes outside the insurance price. So the patient may either have to top up or the facility does not supply it at all. That is a challenge we have sometimes, but mostly we are able to get it at a cheaper price than the open market. And we are sure that the product that they've given to us is of good quality and also very safe.
Okay, thank you very much, Grace, for sharing that. I think it's a good practical example on how some of the big pharma companies are providing access to the EPN network, and perhaps also to our other members. Maybe this can be an incentive also, or a motivation to start looking at some of these opportunities. And I believe the Access to Medicine Index actually provides us with a good report and a good insight, basically, with to choose from which companies we can choose to work with. So the next question, I think, will go to Dr. Joseph Mukoko. Bearing in mind your work implementing and putting in place drug revolving funds. Sorry. Yes, Dr. Mukoko, can you hear us?
Yes, I hope you can hear me.
Yes, we can hear you. We can hear you. Yeah. So,
okay.
So this question is directed to you. Based on the work that you do, especially implementing drug revolving funds, and of course, with bearing in mind, we are speaking about accessibility and how pharmaceutical companies can make access programs more accessible to the low and middle income countries. And also looking at the presentation that we have just had from the Access to Medicine Foundation. So how can the Access to Medicine Index and some of its findings support in strengthening drug revolving funds in low and middle income countries? But then again, are there any specific companies or access programs identified in the index that are particularly beneficial for supporting DRF initiatives?
Yeah, thank you, Mugambi, for that question, and glad to be very much involved in this discussion. One thing that we basically can learn, especially from the work done by the Access to Medicine Index Foundation, is being able to really provide a lot of insights into opportunities that are there and progress that's really being made by various companies. If we look at drug revolving funds in their nature, these are basically kind of facilities which get seed funding, and then they're able to provide medicines at a fairly affordable rate to the patients, of course, with some little markup. So by that, then it means the idea is to be able to really drive the point of access rather than trying to exploit the patient. So that is something that very many settings, facilities are really trying to do. And a lot of these drug revolving funds are either done either in public institutions or even faith-based institutions to really try and see how they can be able to really ensure that patients have a sustainable supply to critical medicines and other critical supplies. So that's something that is key. One thing I'm very glad with the current index is the additional focus beyond just the access. It's also the issue about being able to measure the patient reach. And I think that is one of the key things that everybody at times tends to forget. And I think by working with the institutions like EPN, I think we have really an opportunity. So looking at the work that is done through the Access to Medicines, there's a lot of opportunities to really scale up a lot of the access programs. If you look at the metrics that were being used to measure how the various pharmaceutical companies are doing, you can see a lot of initiatives that are really being put in place. And I think those can actually be leveraged on to really see how you can actually scale up a lot of those access programs, and trying to see how you can actually take advantage of the capacities and the innovations that are really being rolled out by the various players. The other thing that I see is when you have well-structured DRFs, I think you have a very crucial platform in getting critical information as you're looking at filling up your pipelines, being able to invest a lot in more R&D, trying to see how you can ensure that from the whole product supply chain there are no interruptions. I think that information can be very crucial. I use an example like Kenya, where if you see the faith-based sector, that plays a very significant role. And in a lot of those, you find many facilities have to use more like a self-reimbursement mechanism to try and see how they can be able to replenish their supplies and be able to ensure patients have, what they really need. So through that, there's a lot of things that can actually be obtained through this. If you look at how can we take advantage of some of the issues on price, considerations, optimizing the supply chain, being able to prioritize certain molecules, being able to identify molecules that are probably available within the globe, but are not still yet available in some of the local settings. So I think that's something that can be able to really provide a lot of insights. And then the other thing is also providing insights also into the various initiatives by the different companies and the opportunities where the DRFs can also tap into those various companies for mutual benefits. Very many times, it's not just a one way, but it's also trying to see how you can use some of these DRFs as almost, on the law, on the other extreme end, to try and provide and get additional insights into what is really required. I like the idea of the best practices, the innovations that are really being kind of championed by the various companies. And a lot of those provide very rich insights and opportunities that can also be learning opportunities. A good DRF is one that can actually run on its own, be able to ensure that it can be able to attract and service the demands of a lot of their clients. Many facilities are still trying to set up themselves so that they actually have very strong systems. I see if you get into a partnership also through some of these companies, because they are also trying to drive the whole agenda on improving access, I think the opportunities where they can also be able to strengthen some of these systems so that they can actually stand out as strong, that can ensure they can be able to account for all the products that are coming through the system, and they can also be able to ensure they reach all the clients that are really required. If I look at some of the specific issues that you pointed out, access programs that can be able to benefit, I was just looking at, the three technical areas, and in all of those, I could see areas where, there are a lot of areas that can provide insights. If I look at, I know there was governance, through the governance, being able to measure the patient reach, looking at issues of responsible business practices, the governance aspects. I think those are all critical in ensuring that we have a vibrant DRF that is actually operational. If you look at the whole product delivery, and of course, through that, we are looking at issues of health system strengthening, ensure, when you're talking about the human resource, the financial systems, how they handle donations, issue of the inclusive business models. All these are basically operating within a local context. So we have discussions in terms of how does this also link with the local manufacturing capacity, issues of quality and supply of the medicines that are being provided. I think we have a lot of opportunities where through the DRFs being scaled up and working with the members and the partners within the access to medicines, I think all those are areas that can actually provide the opportunities where we can actually be able to do more, reach more, and address more needs on the ground. Research and development looks like that is kind of still has some way to go. But I look at, from the whole planning, we've seen that, and from the report, it's very clear that, sub-Saharan Africa and the lower income countries, they don't have a lot of, the R&D work ongoing. So I think being able to get in there and being able to see how can we be able to include this and identify, ways in which, we can leverage on the work being done by the pharma companies to try and address some of those perennial questions that we always try to find out. How can we reach everybody who really needs to get some of these medicines and ensure that, some of the, the conditions are really kept in check. A lot of the planning that is really required. How can we then be able to do better? How can we ensure that we kind of integrate some of those models into the work that is actually going on? In the settings where we work, very many times you find there are very many parallel processes. So we need to see how, even as we are building these drug revolving funds, how do we build integration and strengthen and ensure that the accountability mechanisms, we can be able to build confidence in the systems and ensure that we are looking at patients as key partners in the whole journey, rather than just looking at them as people where you are selling your products and you get your profits and then you can be able to say you're doing well. So I think that's one of the key things we can be able to look at. I know we can talk about a little more, but this provides a lot of opportunities in terms of how the DRFs, the ATM, the MPP, all of this can actually be kind of brought together so that we are kind of trying to see how the various components can actually learn and leverage from each other. Thank you.
Yeah, thank you. Thank you very much, Dr. Mukoko. And I think you've given very good insights on how DRFs can really function both at the facility level, but also using a network-based system. And definitely, perhaps also due to time, just to forward a quick question to the Access to Medicine Foundation team. I think based on the report, and Dr. Mukoko has also mentioned some of the key areas and opportunities that the EPN network, including the Christian Health Association and the DSOs, can be able to benefit from the report. But also from your perspective as ATMF, where do you see areas for collaboration through our Christian Health Associations and drug supply organization to ensure that we have access and long-term sustainability when it comes to accessibility of healthcare products? Give us some key examples where you can be able to, where some of our members can be able to tap into it and explore further opportunities for increasing access.
Yes, thank you. So reflecting on what has been said before, it is important to understand that the companies that we discussed today in this Access to Medicine Index do not necessarily understand healthcare as it is organized in many countries in the world. And I think the members here on the call today have demonstrated, deep understanding of the pharmaceutical supply chain, the pharmaceutical distribution, how procurement is organized. That knowledge is definitely not present in the companies that we discuss here with you today across their portfolios. Maybe it is there for one disease area, maybe it is there for one country, but it's definitely not true across, for example, the African continent. What these companies need is a partner that they can work with that basically helps them seize opportunities that these companies do not see. I think one of my fellow panelists described it as companies respond to signals, and another said they're opportunists. And this is true. But if the opportunity is not visible to them, or if the signals do not reach them, that is a function that they will lack. Specifically across portfolio and across all African countries. So I believe this is such a strong network the EPN that we're talking to today, that just purely creating visibility on the demand, creating visibility on the pathways that these companies can leverage in and of its own is a very big opportunity for most all of the companies. I already mentioned in my previous contribution that for these companies to now at least signal the magnitude of the problem in low-income countries when it comes to access and the gap there is between even middle-income countries and low-income countries is a very promising first step. But it goes too far to say that it is progress. For that promise to become progress, it is vital that these companies meet with partners that are credible, that have the know-how, that have the capacity and the capability to help them reach these vulnerable populations. So I like to refer back to the topic of this session, which is bridging the gap. That's precisely what's needed. And I see opportunities for EPN and their members, specifically in this area. And I refer to what Sadvi has already presented even to list the examples of implementing partners. I appreciate the example that Grace shared earlier, which is one that we indeed also highlighted in our report. It's that kind of local awareness, local understanding of how healthcare is organized, about how medicines are distributed, that these companies often lack and need to become aware of. So if there's one takeaway message from this conversation for us, and maybe for some of you, it is really to demonstrate your abilities, but also demonstrate, or I would say, send the signals that were referred to earlier to the right people in the companies. We take very strong responsibility for discussing this with the pharmaceutical companies. At the same time, if there is a platform where you meet representatives of these companies, do not assume that the knowledge that you have, the capabilities and the capacities that you have are universal or universally known. Don't make those assumptions, please.
Okay, thank you. And I think I like the closing statement that we are putting. We should not really assume that the pharmaceutical companies have the knowledge and the capacity that we have. So really we need to help them understand our capacity, also help them understand what we do, so that they can also be able to be engaged in our processes. So I will open up the room for any questions from the participants. Please feel free to raise up your hand and mute and ask the panelists any questions as we proceed with the webinar.
In the meantime, Dr. Mugani, allow me to respond to a question from Dr. Richard in the chat, if that is okay with you?
Yes, definitely.
Yeah, so the question is whether the 20 companies are in agreement with the findings. In principle, these are independently drafted by us. We have just concluded bilateral meetings with all 20 companies where our subject matter experts meet and talk to the subject matter experts in the companies. And in fact, the trends that we describe are factual, not necessarily denied or disputed, where there is not, I would say, one unanimous way of going forward is, of course, in the how. And that sort of builds on what I just explained. Some companies have a better sense of what is needed next than others, but the fact that these findings were highlighted as key findings was not so much disputed.
Okay. Thank you for that. And see, we have a question from the participants. Judy, I welcome you.
Thank you so much, Dr. Mugambi. So my name is Judy Asin, and I work at EPN as well. And I have a question for our first speaker from Access to Medicine Foundation. First of all, good job on the report. I think it was well explained, and it has enabled us to appreciate the realities that we are facing in our LMIC's region. And I have a specific question, especially on the aspect of clinical trials. You can see it's very quite alarming that that percentage was very low. I think you had said only 3.5% clinical trials take place in LMICs. And I come from a sector of resistance and the communicable diseases, and also tying it down to the point whereby fewer products covered by the inclusive business models. You can see very few are also under the communicable diseases. And you know, in that sector, we are faced with the problem of resistance. So we are having the aspect of resistance, antimicrobial resistance increasing, but vis-a-vis the rate at which you're having new molecules coming in. And so this is really something that we need to consider. And I have a question in terms of or do you have an idea on what was the reason behind this, this trend when you have very few people actually engaging in clinical trials? And aside from the financial aspect, do you think that also the burden when it comes to standard regulations in country can be a demotivator for the new manufacturers who are coming in with new innovations? And what are your thoughts around, having or advocating for what we call a regulatory sandbox in country? Do you think this could incentivize more trials to take place? Because we need new molecules that are actually working to enter the market. So my question is just, what do you think are the reasons for that low percentage when it comes to clinical trials and, the aspect of the regulatory sandbox? Thank you.
Hi, Judy. Thank you so much for your question. I'm going to quickly try and answer this in short, but I will invite Marianne to fill in if I miss some important points. To answer your question, you are correct. There is, and I like the way how you connected the different key findings to come across the one unfortunate reality, which is the disease burden is going up, but of course the introduction is not happening. And a key component of that is the low clinical trial rates that we see. Very quickly answer your questions, your deduction is quite on point, especially based on also the meetings that we have had with these pharmaceutical companies. The one consistent feedback that we do tend to get is the reason for the low uptake of clinical trials has been the lack of preparedness from the countries. And that, of course, comes with the lack of regulatory standards, as you highlighted. However, while we have taken this feedback from the companies, we also, based on our own bilateral conversations and assessments, realized that for a lot of the LMIC countries, the clinical landscape clinical trial landscape, in terms of the capabilities is evolving. So there are quite a few countries which do have the capacity now, and we're still not seeing these companies update clinical trials in those countries. That is why we wanted to highlight this as a key finding, to say that while we acknowledge that there are limitations which come from a local perspective, there has been progress made on it, and the companies also need to acknowledge it and try and at least start with those countries in terms of expanding their clinical trial presence. But that's my very quick summary of what the report also highlights in further detail. I will quickly check in with Marianne if he wants to add a little more to what I just said.
Yeah, absolutely. Thank you for the question, Judy. Antimicrobial resistance clinical research in and of its own is very challenging. Even in countries where these trials are running, identifying the right patient for your trial is difficult. And then the additional challenge to that is that regulation of these products is different between even the US, the European Union, and Japan. So these three regulatory authorities have bundled their policies and now seem to create a pathway to smoothen clinical trials for products that address drug-resistant infections. Fortunately, what you saw in the slide that Sadvi presented on low-income country trials, that is where the trials focus on communicable diseases. However, needless to say that clinical trial capacity needs to be improved from the facilities upwards. At the same time, companies and also clinical research organizations need to increase the considerations for running trials in low and middle-income countries. I think one very promising initiative for that we've been tracking and engaging with is the Africa Clinical Research Network, run by Dr. Tariro. And that is potentially an opportunity for companies to work with clinical trial sites in Africa that have the potential of being recognized by the stringent regulatory authorities in Europe, in the United States, in Japan, so that trials conducted there can actually also contribute to accelerating the development of products in the US or in Europe. And added to that, of course, is the critical developments in the regulatory affairs in Africa, which without a doubt will be taking away one or two of the hurdles that companies experience when it comes to conducting clinical trials in Africa. So it may be bold to say that there is momentum, but there are definitely multiple factors in play now that could potentially see an acceleration here. So it's the coordination of companies to work with the ACRN. It is the regulatory developments in Africa. And then there is the recognition and the steps taken by stringent regulatory authorities to work together to make it easier to do clinical research with products for drug-resistant infections.
Thank you for that. I see we have another question from the participants. I welcome Frederick Soa.
Okay, hello everyone.
Hello.
Frederick Soa, manager for the food procurement program working with the Catholic Health Services Trust. Sorry for the better part of the session. My internet has been eruptive on and off, so I may have not captured some of the issues that you addressed, but something that I want to find out from you is that for most DOCs in our part of the world, financing, it's one of the major setbacks for a successful supply chain operations and management. I want to find out if your organization has opportunity or works with funding institutions whereby they are able to assist DSOs in sort of trying to assess good quality medication vis-a-vis working with national health insurance organizations in the countries where these institutions are found, so as to be able to enable them access these affordable medicines, as well as being able to take care of their financial obligations to the suppliers and the program's arrangement. Thank you.
Okay, thank you. And I think this can be answered both by the Access to Medicine Foundation team, but also by Tiwadayo. If there's any work you do also from the medicine patent pool. So maybe we can start with Marjin.
Thank you so much for the question, Frederick. In our assessments, we focus predominantly on the supply side, so what the companies are actually contributing. However, in our conversations that we have, we of course speak a lot about the demand, the clarity on the demand, about the demand generation, about how quality control takes place, how that can be pooled for efficiency, for example, without risking unsafe or substandard medicines to circulate. Perhaps for a more detailed response, you could reach out to us after this, so we better understand also where the questions come from, and then also can tailor our response, or perhaps introduce you to the right groups. In principle, we do map these initiatives and these organizations, but I want to make sure I capture what you are looking for. So please do feel free to reach out to us after this conversation. I'm sure the group at EPN will have and is able to share our contact details. Thanks.
Definitely. And maybe I can also invite Tiwadayo to take that, but also as you come in, Mr. Tiwadayo, I think you can also address the question on the chat where Dr. Richard asked, you mentioned a number of incentives to support prioritizations. So do you usually provide licensing support for free to pharma companies? And is there any technical capacity that you can transfer to an organization that at EPN?
All right, thank you. So, I mean, when I started, I didn't provide an overview of MPP's work. Maybe that will help to answer in part, each of the questions. then I'll try to address each of the questions. I know time is almost far gone, so I will be very fast. So MPP focuses on licensing and technology transfer to ensure access. Our work is a bit more upstream than country level demand generation or country level health system strengthening kind of activities. However, we work with a range of partners that focuses on that. So if you need assistance in actually, I mean, just like my ATMF colleague said, if you need assistance in helping point you to specific organizations that can assist in country level, issues, contextual issues in different countries in relation to the access spectrum, we are happy to connect you to that. In relation to the question around if we can provide technical assistance in terms of licensing, yes, we provide we do licensing and technology transfer without charging the companies. We are a public health organization that is funded by governments and also philanthropy. So and because of that, we don't do our work, from the profit perspective. We rather do it in terms of health impact. And the role, for EPN and all other associations that are related, you have a lot of role to play in this space. In terms of licensing, your advocacy work might be informed by having technical knowledge on how licensing is done. What are the elements of it? What is IP? How do you know which product is under patent, etc.? So these are we can provide this information by organizing maybe a seminar with you. You just let us know your availability. We have a database called MedSpa that has a list of all products that are under patent that are relevant to LMICs. So you can easily go to that website and you can see which products could be could have the potential to make a difference in your context, but which are under patent. Because of patent, access is denied. So you can now focus your advocacy effort around that, but you need to even know that first. So we can organize the training for you to be able to navigate those kind of databases, and also for you to be able to know what needs to be done and how it can be done, and so that you can contribute to the effort of getting companies to license more. And lastly, Mugambi mentioned, asked earlier about the impact. So our work has led to a significant impact. We have signed licensing agreements with 22 companies so far. We have sub-licensed to more than 50 companies, and a product like dolutegravir that many of you know, which is going to expire in 2026. We have always, based on our licensing, this product has been available in large scale since 2007 because of licensing. So, and today we have over 24 million people that are on the drug. And this accounts for more than 70% of all patients that are, all HIV patients that are on antiretroviral worldwide. So it's just a little of the impact of the work we've done. During COVID, we also had licenses that have been signed, etc. So please feel free to reach out, or you visit our website if you need any additional information or assistance. Thank you.
Okay, thank you. Can see Grace has a hand, but we are short on time. So Grace, I'll give you just 30 seconds and then we go on to the closing remarks. So welcome, Grace.
Okay, and thank you, Mugambi. I wanted to just use some few seconds to highlight some of the challenges that we are having as far as the access is concerned. That is why maybe my colleague is asking about how we can get some funders to support us. So even though we have an arrangement with Novo Nordisk and through a local distributor, the arrangement was that they
Hello, Grace. I think we lost you. Yeah, I think we lost Grace. But I feel we are out of time for the webinar. So I think we would like to close this webinar here. So I will welcome Dr. Richard from EPN to give us our final closing remarks. Again, thank you very much to our panelists. Thank you very much to the Access Medicine Foundation team. This has been a quite engaging and learning session from you, team. So welcome, Dr. Richard, for our final remarks, and please close out this webinar for us.
Thank you very much, Dr. Mugambi, and I would like to thank our speakers for your time and this wonderful webinar and good insights. We really appreciate, and I would like to continue to commend our collaboration with Access to Medicines Foundation, which has been, we think we are learning a lot from the index, and we take note of the key recommendation done, which are very, very useful. As mentioned, we need to document more the impact of the access, and EPN being largely based in low and middle income, 27 countries in Africa, close to the patients, we can really give more insights on how this program is impacting lives. And we are committed for that. But also on the policy side, we are happy to partner. It has been mentioned by Access to Medicine Foundation, but also by Ibrahimo, that it's important to engage and we need the right information. So the index is one of them, but also we are really happy to continue engaging with MPP so that we can really use all the possibilities out there to shape our advocacy efforts. So thank you very much for the time. We wish we could hear more about our participants, but I think the webinar was very packed. We had a lot, that it's what we needed. We need to create that focus on the importance of driving access and how we can participate. EPN and members, we will continue the engagement and ensure that we really define a clear roadmap on where we can start as you plan for the 2027, is it 2026 index report. Yeah, I hope we will have enough insights from the ground which can be really shared. But also, we appreciate that you consider the feedback. This report has a number of our feedback, and we are really appreciate as you continue, we are ready to support. So thank you to all our participants for being here the 2 hours, and we hope you enjoyed the webinar, and we look forward to more engagement with you. If you have any question, colleagues have shared their email addresses. You can reach out to one of them, and we will consider seriously your questions. And if it requires to rely to the response from our speakers, we will do so and share the response with you. But also the webinar is recorded, and we'll share the recording with all the participants so that they can be able to follow it after the webinar. Thank you very much, and I wish you a very good evening